Okay, so I want to thank, first of all, Gita and Argun for inviting me to this meeting and to present what Mr. Chairman just said, is talking about endometrial receptivity test and the other side of the story, as we just heard. First, it was the embryo, and now I will look at implantation from the endometrial perspective. We know that it is also a limiting factor in achieving a pregnancy. We know how difficult it is sometimes to put the embryo in the right time and the right place, and it's easy to do the embryo transfer, but we never know if it's going to happen, if it's going to have a pregnancy or not. And even we are always doing these IVF cycles in kind of guessing. We don't want to transfer too many embryos because we have the risk of multiple pregnancies. Sometimes the couple is arguing that we want to have more than one embryo because otherwise it's not going to be a high chance of pregnancy. And sometimes we just don't understand what is going on. And there are so many things for us as clinicians that are far away from understanding, that we just get some information from people like Professor Van Bleckholm right now. Basic science moved into clinical side, but for us, we have simple minds. We just try to explain what we're doing, but it's not really easy to understand. And I disagree with the previous speaker because he said that the main focus has been put into the endometrium, but I don't think so. If you type in your database embryo, IVF, or ovarian stimulation, or things like that, you will find thousands of papers. If you type endometrial receptivity, you roughly find 1,000 papers. So even though there's been a lot of people working on this, it's really an area that has been neglected because I think most of us thought that endometrial receptivity was always the same. The implantation window was the same for all the women, and it was more or less equal for everyone. We didn't personalize, as we usually do, the stimulation phase. So the concept of endometrial receptivity, as you all know, is this time period, this restricted time period when the uterus is receptive to blastocyst attachment and invasion. So this is the other point of view. It's not how the embryo is going to identify the endometrium, but how the endometrium is going to identify the embryo. And this concept, as you know, frames the period in which the embryo may attach. We think, and we have this concept in mind for many years, that it's usually 4 or 5 days of the month, and it's usually related to the peak progesterone levels. This is where the synchrony between the blastocyst and the endometrium should happen, and it usually starts after 19 or 20 days of women with regular menstrual cycles by losing the epithelial receptors of estrogens and progesterone in the endometrium. So this is usually what we know. Endometrial receptivity is a specific time period in the menstrual phase. So we could look at it more or less like a Teflon for the days that the endometrium is not going to implant, and like a Velcro for the days that the embryo is going to attach. So we know that just for a few days, the Velcro is going to be there. The rest of the month is going to be like a Teflon. You can put embryos any other day, they will never implant. There are many things that we don't agree in the luteal phase. I'm sure if we make a question around the room, when do you start progesterone in your treatments, and when do you stop progesterone in your treatments, probably there will be a huge disagreement because it's mainly empirical. There's not many studies on it. And even if the studies are there, we just have difficulties in changing our practice from what we have learned in the past. Similar for the endometrial receptivity, we tend to think it's always the same, and we still, in some units or in some countries, they still rely on the NIOSH criteria from the 50s, which was a huge advancement at the time by immunohistochemistry. But those criteria are good for endometrial dating, so they can tell you which day of the cycle this endometrium is, but it doesn't say anything about the fertility status. So there are many other technologies that you have there outlined, and I'm not an expert on them. I'm a clinician, as I said, but it is sometimes difficult to follow this research, but we have to, at the end, try to change our practice if any of these technologies are meaningful. So we have to understand how accurate they are, we have to understand how reproducible they are, and if they have any clinical utility or not. So as I said before, I think we are in 2015, and we know how personalized medicine is getting bigger and bigger, and it makes sense. One size does not fit all. And patients are different, and we do that with our patients in infertility treatments. We individualize the dose of drugs that this woman may need by AMH levels, BMI, age, antral follicle count, you name it. we're going to decide, well, we should follow this protocol, or maybe not this protocol, maybe we should change the protocol, maybe we should go for conventional IVF, or maybe because there's a male factor, we should do ICSI. Maybe one embryo is good for this woman, maybe two. But then when the luteal phase comes, we assume that everyone is the same. We think, and actually we do, that the endometrial status at embryo transfer is treated equally. And mainly because there is a neglected customized approach. We tend to think that we assume that the luteal phase and the implantation is going to be the same. And this is mainly based on the lack of knowledge that we have. And I think that today there are quite a few, well, not quite a few, but at least 2 or 3 endometrial receptivity tests that are appearing, and these are just the version 1.0, I guess. These things should develop further, that we can actually time embryo transfer. So we have to rely on technology, and we just heard a very nice lecture on how very precise technology can measure the energy within a cell. And this is a very simple example, but look at 1956. This is more or less the time of Noyes criteria. And to take a hard disk who had 5 mega, a plane was required. And 5 mega is more or less the size of this PowerPoint that I'm using right now. So if I had to fly from Spain with my presentation, it would be much more expensive than my flight. However, today you can have 50,000 times information in this thumb drive. So we have to use technology. We are in 21st century. And this is the time of omics. But it is true that whether you are an embryologist or a scientist or a clinician, actually I think it doesn't matter. We have to go down and try to understand this language and talk to people who really understand this. And we have to take advantage of that and understand what is the transcriptome, or what is the proteome, or what is the metabolome, and if this is reproducible, and if this is going to help our patients or not. The group I work at in IVI, led by Carlos Simon, they have been doing a lot of extensive work on endometrial receptivity since 10 years ago, 12 years ago, and they published a few papers that you have here in red, trying to frame this window of implantation, trying to understand which are the genes that are going to be up or down regulated, but are meaningful, as we just heard in the discussion. There's always genes going up and down, and this is usually very confusing. But if you do the right work, you may find that this is maybe meaningful or maybe meaningless, but it seems to be some critical information there. So with those previous basic research, they came out with an endometrial receptivity array, which is something that you can use with patients, trying to understand if this, the 238 genes that should be expressed at the precise time of the window of implantation are expressed when we expect them. So it's a customized microarray. Obviously, we're going to have someone to analyze this for us, and then they are going to tell us as a predictor whether the window of implantation is receptive, pre-receptive, or post-receptive endometrium. So this would be a receptive profile. You have down here the more than 200 genes that are analyzed, and you have here a nice profile of a receptive endometrium, and this would be a chaotic endometrium with a non-receptive endometrium. So this bioinformatic analysis is going to tell us what would be the receptive endometrium here, and you have pre-receptive or post-receptive in a very simple report. So we first used to do this biopsy either with a natural cycle or based on HRT cycle by giving estrogens and progesterone. We biopsy either LH plus 7 or P plus 5 as usual, but we tend to do more and more hormone replacement therapy cycle, mainly because LH is tremendously variable. You have this paper from France, from Direito, that was published in 2013, and you can see how the LH surge and the LH peak can be tremendously variable. So you have short, medium, double, or prolonged LH surge, and you have single, plateau, double, or even multiple LH peak. So how can you rely on your biopsy if LH is really not so reproducible? So I think it's much more informative to do HRT cycle if you really want to time this window of implantation. In fact, in this same paper, they show that ovulation may happen at the onset of this LH peak. It could ovulate during the LH peak, at the end of the LH peak, or even after the LH peak, when they were doing ultrasound at the same time. So it's really not precise enough, because biology and nature is not so precise, as we all know. So how accurate is this endometrial receptivity array? They did this blinded study comparing ERA with 2 expert pathologists. And as you can see in black, you have the hits of ERA compared to the pathologist. And when they were trying to time the pre-receptive, receptive, or post-receptive status, ERA was significantly better than expert pathology. So it seems that technology is actually helping us to be more precise on the receptivity status. This is about accuracy, and this will be about consistency. So we may biopsy endometrium this month, and we will have a diagnosis. How is this going to happen in the next cycle? Because we know this may change cycle to cycle. So what they did is to rebiopsy the early studies participants. So women who have had a biopsy a few months ago, between 29, 30, even 40 months ago, they came back to the clinic, they took another biopsy, and those that were receptive remained receptive, and those that were non-receptive remained non-receptive. So it seems to be quite stable across time. So it's not something that you have to be insecure about how relevant is going to be the information I get this month for the next month. It's going to be the same. So we started to use this test in difficult patients, as usual, in women with repeated implantation failure. And this was the information that we had in some difficult cases, 85 women with recurrent implantation failure. You can see the age of the patient compared to controls is similar, about 38, 39. Most of them had receptive endometrium. So this is something that we have to have in mind. The main player here is the embryo, and I think this is where we have to focus. Only about 10 to 15% of the controls may have a non-receptive endometrium. It's up to 25% in recurrent implantation failure, but still 75% the endometrium is fine. So it's a problem with the embryo most of the times. But in these difficult women who had at least or a mean number of 5 previous failed implantation cases, we were able to normalize the implantation and pregnancy rate. So of course, this is not the ultimate answer for everything, but you can normalize your results if the endometrium is in phase. Whether this is related to the embryo biopsy or not, because we may say, well, you do the biopsy, and then next month the woman is pregnant. So some of you who believe in endometrial scratching, if any, you may think, well, this is because of the beneficial impact of the endometrial scratching, but it is not. Because if you look at the month after the ERA test, you don't have more pregnancies in the first month immediately after the endometrial biopsy, 2, 3, 4, 5, or even 6 months. So these are non-significant differences. So this means that it is not related to endometrial scratching, and we will see large studies that are being run actually on that topic, showing some interesting results very soon. So for those who had non-receptive endometrium, there were difficult cases, as I said before, 5 number of cases compared to controls, and most of them were pre-receptive, some of them were post-receptive. And as I said, you could normalize the results, which is quite interesting. So what we are learning in this time now is that the assumed one-size-fits-all window of implantation, we understand today that it is not like that. In some women, this window is displaced and is 2 days later. In some women, it's 2 days before and is moved in front. And some women, what they have, and I discussed this previously with you, they have a very narrow window of implantation. Instead of being 4 or 5 days, it may be 1 or 2 days. So this makes, at least our understanding is that it makes it quite difficult for these women to have a spontaneous pregnancy, because it has to time the intercourse according to the window of implantation, which is extremely difficult, but we can time the embryo transfer for her in this case. I'll show you an interesting case report. It's a case report in a pilot study, and of course this is the early times. We need more data, but this is a very interesting case. This case, these women came to us after 2 failed IVF, first embryo transfer, day 3, beautiful embryos. And as happens in most infertility units, people shop around and they want to see what the other doctor can say. Maybe they have different lab, different things. So she came to us and we did 2 more IVF cycles with fresh blastocyst, thinking that maybe it was a development in the embryo problem. It didn't work, so we tried again, and we went to segmentation because it's the trendy thing, so we froze the embryos, we waited for the normal endometrium, natural endometrium, and did a natural cycle embryo replacement. It didn't work, so after 4 IVF failures, we thought, well, maybe it's an oocyte issue, so we suggested egg donation. So we did 1 cycle here with day 3 embryo transfer, nothing happened. Again, another cycle with natural cycle, nothing happened, and then we went for blastocyst transfer, nothing happened. So this is very frustrating, right? 4 IVF, 3 egg donation, most couples would just stop it and maybe think about adoption or something else. So we did ERA tests in these women, and we found that the endometrium was pre-receptive at day P+5, being receptive 2 days later. So we did personalized embryo transfer using day 5 blastocyst, but putting the embryo after 7 days of progesterone, something that we never do. And she got pregnant with twins, both of the embryos implanted. So, of course, this is just a case, and you never know if it's only because of the moving of the window, but of course, this is extremely supportive of this concept. So we collected some data of these previous cases, 17 cases, in which, as you can see, these are egg donation cycles. Mean age is quite high, obviously, almost 41. Mean number of embryo transfer, 1.8. And as you can see here, these are the previous cases in which either first attempt or cumulative case were very poor, and the ones that got pregnant miscarried. So in these bad cases, we individualized the window of implantation. We did ERA tests. We found most of them pre-receptive and some of them post-receptive, as you can see here. And when we moved the progesterone to adequate the timing of the embryo transfer with endometrium, we could, again, normalize the results. You could have a pregnancy rate around 52%, and still some biochemical pregnancies here, and the cumulative pregnancy rate that you can see here. So again, in these difficult cases that you have quite a few previous failures, you can more precisely time when the embryo is going to be receptive for the endometrium, but from this point of view, when the endometrium is going to be receptive for the embryo. Of course, this needs to be validated in a prospective trial, and this is what we're doing right now. We are randomizing quite a large number of patients. It's almost 2,500 patients across the world. It's a 3-arm study, and prospective randomized, of course, and we're going to randomize women who are going to have a fresh embryo transfer, frozen embryo transfer, or ERA-tested embryo transfer. And here they will be allocated to 3 arms again. So we may have embryo transfer according to the ERA test and embryo transfer regardless what the ERA test says. And this will be the only way to understand if this is really helping patients or not. This is, as I said, an international multi-center trial. There are many centers across the world doing it, and if any of you is interested, we're still open to welcome any other group who is interested in doing the study. And we hope to finalize by 2016, because it's quite large, but by that time we will understand if this is helping all patients from the first day they come to see you, or if it will be only 4 difficult cases of repeated implantation failure. Obviously, this is the version 1.0. We have to keep looking further and talk to the scientists who really understand what is the knowledge, because this is still semi-invasive. We have to take a biopsy of the endometrium, and of course, if you take a biopsy of the endometrium in that cycle, we cannot transfer. So this group is still working on the proteomic signature of this receptivity, trying to understand what is the next step of the RNA going into proteins. And there are many people working on this. There are many people trying to find what are the biomarkers of endometrial receptivity. Most of them are known to you, I'm quite sure, because there's a huge interest in trying to be more efficient. We know how to stimulate the ovaries, you know how to do embryos, how to create embryos, how to culture them up to the blastocyst stage, but we are still extremely inefficient. Many embryos are transferring to the uterus and are being lost. And we don't know if it's because the embryos are not right or maybe because endometrium is not right. One of these biomarkers that the group of Carlos Simon is looking at is what it's been called lipidomics. And it's prostaglandin concentration, not in the biopsy, but in the secretion. So instead of taking the biopsy, you just aspirate a few microliters that you can take from the endometrium. And we're looking at these 2 prostaglandin concentrations in the endometrial fluid. They published in the ACM 2 years ago this paper in which you can, with some precision, as you can see in the ROC curve, stipulate more or less who is going to become pregnant or who may not become pregnant in day 3 embryo transfer. But interestingly, when you go to day 5, it's not so relevant. So again, this is just preliminary data, but we're trying to understand how to be less invasive and more informative by looking to the next step of the genes So we can conclude that the transcriptomic signature of the endometrial receptivity revealed that the endometrial factor is responsible of 25% of the cases of patients with recurrent implantation failure and about 10% of the general population. When we did this personalized embryo transfer, I think we could normalize the results. We couldn't have 100% success, I wish, but this is not the truth. But you can normalize the results according to the results that you have in your unit. And I think we will be able to investigate this endometrial receptivity through non-invasive biomarkers, maybe lipidomics in endometrial secretions. Thank you very much.